Hi, this is Brandon Steele with ChiroUp. I want to start with impingement syndrome. Now, the prerequisites to this CE class are really your upper cross syndrome and also scapular dyskinesis. A lot of times your postural problems and repetitive stresses can lead to a syndrome or a problem, and we want to make sure that we understand the functional deficits that can lead to an orthopedic condition like impingement syndrome. So the big thing with impingement syndrome is it's not a specific diagnosis. And a lot of times people will assume that it's that supraspinatus that's being impinged and that's causing the problem. Now, the simple fact is we really don't know what structure is causing the problem. It could be, and most likely is, that rotator cuff, the top piece of that shelf there. However, it could also be the bursa. It could also be the biceps tendon. It could also be the labrum or something within the joint. So we want to make sure that we understand that impingement syndrome is just a syndrome. It's kind of like fibromyalgia syndrome. It's a collection of symptoms. So we want to exploit our knowledge of how the shoulder works, do a couple tests as far as orthopedic and functional tests, and then we can really get into what we think is going on, the hobbies, the habits, the sports, the postures that's causing impingement and resultant pain. So impingement syndrome is the #1 diagnosis that you're going to see coming into your office. And the reason for that is because this happens so frequently. And there's a lot of different reasons that can happen. Most notably, as we get older, unfortunately, our rotator cuff will atrophy and become less strong. And then we'll start to see migration of the humeral head upward. And we'll explain that as we get through this lecture. We're also going to see the activities of the patient cause a lot of these issues. Overhead activities, painters, people that are constantly picking their arm above their head, people who do ultrasound, people who have their arm up all the time. Typing can do that. Also, our postural stresses, the things like sleeping on our shoulder cause constant compression and issues with the shoulder. So we want to make sure that we understand where the impingement's coming from, and then also make sure that we can take care of it, and as far as improvement with our management, with our passive and active treatments, and then also the modalities and ADL modifications. So when we talk about the glenohumeral joint, this is where most people think there's a problem, and they would be correct. That's where most of our issues happen, but that's just because it's the weakest link. This is a joint that sacrifices stability for mobility, and for a good reason. We need the glenohumeral joint to move in this way. Unfortunately, when it moves too much, or things up and down the chain aren't moving enough, this is really the joint that takes the brunt end of dysfunction. We like all of our joints to be centrated, meaning they're able to bear load. They're able to share the load. So if I have to move my arm, some of that load comes through the bone hitting cartilage. Some of it comes through the capsule. Some of it comes through the ligaments on the outside of the shoulder, and some of it comes through the muscles. And so with purposeful movement, any kind of throwing activity, picking up something, we're able to distribute that force through all those joints, all those muscles, all those ligaments, so we're not overloading one versus the other. Unfortunately, with any kind of dysfunction, with our upper cross syndrome, with our scapular dyskinesis, with the shoulder not moving properly, we have to disperse more load through one of those structures, and we get resultant pain. Now, pain is not a bad thing. Pain is a warning sign. It's a check engine light. We can do an anti-inflammatory. We can do an injection to take away pain, but that's still not fixing the problem. We can't cut the wire that goes to the check engine light and expect our engine to still function normally. There's a problem there. So don't think of pain as a stop sign. Think of pain as a signal to say, hey, something's going on here. Let's exploit what we know about the patient, what we know about orthopedic testing and functional disturbances, and let's figure out this riddle and come up with a plan to get this person out of their pain and hopefully improve function as we go along. Now, when it comes to impingement syndrome, I do want to cover just a small piece of the etiology behind why we get impingement syndrome. And a lot of this is due to movement. Now, when you pick up your arm, mostly in abduction, but also a little bit when you get into the scapular plane, we need the humerus to do one thing specifically, and that would be to have inferior slide. And that's what we're going to see right here. That we need to make sure that this ball, which is our humerus, slides downward. And if it doesn't, that's when it's going to start to roll upward, and there's a problem there. There's something hard on top, and that being the acromion, and we also have the coracoacromial ligament connected to the coracoid that is a roof essentially over that bone. There's squishy stuff in the middle. There's pain-sensitive structures in there, and that's what we'd call an impingement syndrome. So once we get up into those ranges where that arm is supposed to move really past 20, 30 degrees, we need that motion. People who do repetitive stresses, and in fact swimmers are a culprit of this, and when they get a lot of tension in the ligaments underneath from a pulling motion, they can get tension and injuries along the inferior glenohumeral ligament, and it can start to push us up. Our throwers have a lot of issues with posterior capsule tension where the arm is not moving properly and can predispose somebody to this condition. Just sleeping on your side for long periods of time creates joint dysfunction, as we know as chiropractors. So there's a ton of different reasons why this joint could be restricted and not moving properly, but there's nobody better to assess that and nobody better to treat that than we are. Now, this is a good graphic of what's going on, but what you can see here is that if you just go through 22 degrees of abduction, picking our arm up slowly, right? That's not very far at all. If this joint, this humeral joint, does not translate downward, it's going to start to go upward, and that's going to go about 10 millimeters after the first 22 degrees, and that's when I said that we're going to have our impingement happening. So we need to make sure that that 1 centimeter translation upward doesn't happen. Now, most of us think about a joint should work properly, and we're great at treating joints as far as with manipulation and mobilization, but this is one of those joints that is very difficult because it does sacrifice stability for mobility, so it does have a lot of range of motion. We need to make sure that we address the most important ranges of motion and not just global range of motion. So things in the glenohumeral joint being a loss of inferior glide, and what we're going to see in the next couple slides, a loss of internal rotation. So those are the things that are really creating this issue that we need to address in our office and also with our rehab. So once again, this slide shows you that what we have here is some irritation here. Now, I want everybody to do one thing for me. And all we're going to do is I just want you to bring your arm slowly up. In fact, if you really want to create impingement, roll your thumb downward so that greater tuberosity rolls into interior rotation. And then keep it and go as far up as you can. Now, some of you may experience pain when you do that. Pain in the anterior or anterior lateral shoulder. That's a sign of impingement syndrome, but we all impinged ourselves. So when we're bringing our arm up like this and forcing that greater tuberosity under that acromion, we are pinching that structure, the bursa, the muscle, the ligament, the labrum. All those structures are getting pinched. The question is it causing symptoms or not? Because that's when we know that something underneath there is reproducing our symptoms. Now, if I bring my arm up and I get numbness and tingling extending down my forearm, well, that's still impingement, it's still a positive test, but it's not reproducing the symptoms that would be associated with an impingement syndrome. That may be more of a radial tunnel syndrome or cervical radiculopathy causing those kind of pains. And we'll go over how to differentiate those within this lecture. One thing that I do want to cover is that the impingement syndrome is often thought of as a bursa issue, a bursitis. And we hear this all the time in the shoulder and also down to the hip that we have a bursa problem. Now, that can be true. That is possible. But what we're noticing from the literature and what seems to make the most sense when you look at most of your patients, if it was a bursal issue, an inflamed bursa, that's a chemical problem. That problem is going to be there all the time. It doesn't matter if you're here, if you're up here, or you're doing anything. An inflammatory issue is a constant chemical irritant. So that's going to be painful all the time. What we see most often is it's not actually the bursa that's inflamed. It's not often the bursa is causing symptoms. Instead, it's what's underneath it as far as the rotator cuff. So we're going to cover that in these slides. exercise. So yes, we can see inflammation in the bursa. It does happen. So I don't want to say it doesn't. However, if you talk to most radiologists, you're not going to see irritation in the bursa. In fact, most of the current research is pointing to the bursa is a site of actual mesenchymal cells to actually help with the inflammatory process. When it inflames, there's another issue happening, that being just below it at the supraspinatus level. So I want to make sure that we understand, even if it's inflamed, it's beneficial. It needs to be there. Now, when we're going through our range of motion, there's a big piece of this that is, arthrokinematics and understanding how the joints move, but also if we have a clear understanding of how it's different when you move your arm in a scapular plane versus a frontal plane, we can really start to get some information on how we can help our patients go through their rehab process. Now, when we go in the frontal plane, this is often not the most, it's going to cause the most symptoms, and the reason is because of this orientation here at the greater tuberosity. So we're creating a little bit of a disadvantage at the shoulder. If we can move it into 45 degrees, so if this is 0 degrees, move it into 45 degrees, that's more of a scapular plane, and now I have this mismatch here where I can get a little more range of motion out of there. So when you're doing your exercise, if something hurts when you're bringing your arm out to the side, it's possibly not a great idea to keep on doing that and re-irritating it. It's a much better idea to move them into more of a scapular plane to help avoid that compression. Another thing that we highlighted about 5 minutes ago was internal rotation. And as you internally rotate your humerus, you're going to take that greater tuberosity and put it under that coracoacromial arch and cause more symptoms. So if somebody's having pain or problems and you're having them do some like empty can type exercises and it's causing too many symptoms, you can have them roll outward. And what you're going to notice is that if you roll your thumb outward, kind of like a Brugger position, that supination clears that space. It makes it much more easy to do that range of motion. It's very similar to maybe a pull-up. If someone was doing pull-ups and they had their hands internally rotated and going and doing a pull-up, that creates a lot more pinching at that shoulder joint as compared to if you have them reverse their grip, which is much easier on the actual shoulder. So we could take advantage of that knowledge when we go into their ADLs. We can go into their rehab exercises and make the appropriate recommendations to help them get through these symptoms. Now, when I was in school, which wasn't that long ago, but I guess it was long enough ago, that we had structural issues causing pain and problems. And what we know now is structural issues are there. Is that we can't deny that. When somebody has stenosis of the lower back or has degeneration of their neck, that is a complicating factor. It's a sign of long-standing dysfunction and is something that should tell us something. The thing it should not tell us is that that structure is causing that pain, because what we know is that's not true. One of the things that I tell my patients when they come in and they have x-rays and they've seen their primary care doctor, they've seen pain management, and they said, yeah, I've got this pain. It started 6 months ago, and they did an MRI and they did an x-ray, and I've got this horrible bone-on-bone problem in my lower back. Well, that bone-on-bone problem has been there for many years. Your pain started 6 months ago. So I'm not going to deny that it can cause those symptoms. It's not, correlated with it, but it's not a causation type situation. And the same thing happens with our acromion. People aren't born with these types of acromions. What I want to bring up though, is that if you look at this bone and you look at this bone, there is a ligament going between here. And that ligament is, I think, the source of this extra bone. This extra bone is very similar to a heel spur, that if you take the plantar fascia and you constantly create tensile stress across it and you don't give it enough time to heal, your body eventually says, after a couple weeks to months to years, it says, you know what, I'm done trying to heal this area. I'm just going to lay down bone. And that's what we call a heel spur. And as we all know, with the heel spur, that's not a painful structure. Instead, it's indicative of a functional problem leading to a structure that we're seeing on an x-ray. The same thing that is happening here. So I'm not going to deny that there's a problem here, that we get these type 3 acromions. However, this is a sign of glenohumeral instability. It's not the cause of impingement. Is it perpetuating impingement? Yeah, now you have a ligament that is somewhat pliable, that is able to expand based on the arm motion, and now we're replacing it with bone, which, as we know, doesn't move very well. So you are creating less room to move. It's your body's attempt at stabilizing this joint. So what we're going to see here in graphic is here is your coracoacromial ligament. Normally a nice taut ligament, and what we know from baseball pitchers is that as you actually go through your range of motion, that you're going to actually get this to expand. You're going to see separation and bowing here like this. That might be a little bit much, but what you're going to see is that this is going to arch up like this, and that's okay. That's what it's there for. Why else would you have a ligament that's already connected by two bones? That you're creating a pliable roof, and that pliable roof is there to serve for functional stability of the shoulder. And if we can't have functional stability of the shoulder and we constantly move this up and up and up and create pain and problems, that's where we're going to start to calcify this area that we're going to see with those type 3 acromions. So what causes impingement syndrome? And I wish there was A plus B equals C, but the simple fact that does not exist. That kind of deductive reasoning doesn't happen in the body. We just don't have those kind of things. We have certain things that are correlated with problems, but very rarely do we see causation in light of maybe trauma where we see a causation. The auto accident caused this, but a lot of our repetitive stresses aren't that way. They have a couple things that are going on, and when those couple things happen in succession, and we have our jobs and the way we sleep and the way we drive our car, that eventually leads up to our condition. So what I tell patients is that, listen, this is a problem. The things you've been doing in the past have created this issue. If we keep on doing those things in the future, it would be ludicrous to think this thing is going to go away. There's some things that we need to solve. Now, there's some things that we need to change or we need to eliminate, and that's the stuff that we would call rehabilitation. Now, when it comes to, unfortunately, jobs, I can't say, Brandon, you need to stop being a chiropractor because you have shoulder pain. That is a risk factor. It is a correlation with my shoulder pain. However, I still need to work. I still need to provide for my family, and so do your patients. I can't tell a carpenter to stop being a carpenter, an electrician to stop being an electrician. We need to find out the specific movements, the specific things they're doing on a regular basis, and go about correcting those things. Now, when it comes to a sport, there's a lot of different things you can do. I used to do a lot of sports-specific type training, and there are things that we can do to help people. If you look at baseball, just changing the slot angle of the arm can make a big difference. With archery, worrying about their elbow positioning. So there are little small pieces of this puzzle that we can attack to help get these people out of pain. And hopefully the end result is to keep them out of pain and keep them in, one, their sport, or two, their profession. Now, when it comes to stages and looking at where does this person fall within the continuum of shoulder dysfunction, what we know is at the very beginning we have functional problems. Those would be more of our upper cross syndrome and our scapular dyskinesis. Those are painless diagnoses. As soon as you hit a painful diagnosis, a tissue has been injured. A tissue has been is swollen, is torn, is ischemic, what have you. That's when we start to see these kind of diagnoses. And if you do that kind of activity for a long period of time, tissue will change. So tissue at the very beginning wants to heal. That's the beauty of being a self-healing organism, that we have an injury, your body goes through an inflammatory process, we're able to bring some blood supply to the area and then get all the damaged tissue out of there, and we have healing. Unfortunately, due to the current nature of our jobs and our activities and our sports, is that sometimes we don't give ourselves enough time to rest. If you look at Little League players, if you look at young hockey players, they're practicing every day, every other day, and this pain turns into a chronic issue with chronic swelling and chronic problems, and that turns into a point where you start to see a change in mechanics. And when I say that, I say, if you have a pain or a problem in your foot and you keep on walking on it, you're going to start to walk differently. If you want to do this very quickly, put a tack in your shoe and try to walk to the door. See how far you can go without changing the way you walk. Your body will find a way. Your body will get from point A to point B, it'll just normally do it at the sacrifice of other joints. The same thing in the foot. What happens when somebody has long-standing plantar fasciosis is they start to walk on the outside of their foot. Now, if you look at somebody with a shoulder problem, what are they going to start to do? They're going to start to use their upper traps in their neck to move their arm. So they're going to go through those compensatory ranges of motion, and compensatory structures are going to help with their movement that has been sacrificed from this injury. Unfortunately, when you start to take joints and muscles and ligaments and have them do something they're not designed to do, that's when we come up with these pains or problems. And if it's been going on for long enough, that's when we see our tendinitises turn into more of our tendinoses. Tendinosis is probably not a word, long-term tendinosis. Stage 3 is when we really have a problem. That fibrosis becomes so big, it's become such a big issue, it's disrupting so many fibers within that rotator cuff that now it's actually not able to perform like it's supposed to be doing. So stage 2 is pain and dysfunction. Stage 3, that's when you're going to start to develop weakness. And that's when we start to classify things as more of a rotator cuff syndrome as compared to an impingement syndrome, when that tissue is pretty much too far gone, unfortunately, and may not go through a normal healing process. So when we go through symptoms of the impingement syndrome, unfortunately, it's this. And the reason I say unfortunately is because a lot of things can cause pain in the anterior lateral shoulder. So we really have to look at what are the movements, what are the positions, what are the activities, what are the time of day that those symptoms are present, because that will start to lead into, is this truly a shoulder problem, or is this more of a neck issue or something else that we need to dive deeper into? So our sharp pains, localized pains that happen right here very often are a shoulder issue. If we start to see sharp shooting pains going down the arm, we'd be more inclined to think that was a radicular type symptom. Also, our activities that cause internal rotation, something like tucking in the back part of your shirt, fastening a bra, going into your back seat to grab something, those are all things that are aggressive internal rotation of the shoulder that can cause these kind of symptoms. The last piece is nighttime pain. Now, nighttime pain is a red flag, so I don't want to make light of it. However, we would expect nighttime pain with an impingement syndrome. And the reason is that when you sleep on your shoulder, you're creating compression on that side. And that compression can cause ischemia. And that ischemia can cause pain. And some people say, well, I don't sleep on that side. I sleep on my other side. The next question that I would ask that patient would be, what is your other arm doing? A lot of times it's across the body like this, which we're going to see can create impingement and problems. Things like hugging a pillow will help with those symptoms. There's some things that we'll cover in the next couple of slides that can also help with that. We'll cover it right now. One thing that I have my patients do, this is my opinion on one thing that has been successful for me, is that patients often don't like to change their activities. And especially when Bob and Sally have been sleeping next to each other for 50 years, and Bob sleeps on the right and Sally sleeps on the left, and they don't want to switch sides, and Bob always sleeps on his left shoulder, and now he has left shoulder pain. Telling Bob to change a 50-year habit is not very easy. So one, I'd much rather have Bob lay on his back, but sometimes that's not possible. So one thing that I've done with my patients is I've had them take a very thin pillow and put it across their torso just before their arm, and then use a thicker pillow where their head is to create a crevice and to create a little bit of a space there that you're not causing as much compression, which can help with that ischemia and resultant pain and development of impingement syndrome. It would be foolish to think that I can heal somebody, or they can heal themselves throughout my care, if every single night they're causing compression to that area. And the reason is because if we have pain and a problem, we often have a tissue injury. That tissue injury has to go through a healing process. Healing requires blood, and blood does not respond well, cannot get to that area if you're constantly compressing it. So while some people will do the same thing to every single patient, I do this, this, and this, if you're not attacking the things that are often contributing to that orthopedic diagnosis, often you're going to be frustrated, and the patient will be even more frustrated because they're not getting the results as fast as they would expect. And I'm not saying you need to change everything that a patient does, but change one thing per week, 2 things per week. That's it. And if you can modify the most important stuff, then they can start to see their progress and they can help get them out of pain just a little bit faster. That was brought to my attention. A great line is that an educated patient is a compliant patient. And I love that saying because the more that I can educate a patient on what's causing their shoulder pain, the more compliant they are in my directions and my recipe to help get them out of pain and their problem. And hopefully the results are that education can prevent them from doing things in the future. Very often I'll have a patient who has a pain in their back, let's say, and they want to go back to exercise. And I say, what's exercise? Well, I want to do this, this, and this, and they list off 15 things. It's much better to say, as of right now, I don't want you doing anything unless you're laying on your back, because then it can educate them that anything standing up is probably not a good thing. It's intuitive to the patient so they can understand what exactly they can and can't do without really listing out all the specifics. So for this case, causing constant compression of the shoulder is a bad thing. Keeping your arm up for a long period of time is a bad thing. So hopefully they can, through reasoning, decide what's going to be good for them and what's not going to be good for them. Now, I'm not talking a lot about manipulation in this class, as you can tell. I am a chiropractor. I love manipulation. I love mobilization. That's the reason I'm in this profession. When it comes to the shoulder, we don't see a lot of good peer-reviewed literature as far as manipulation, which is high velocity, low amplitude manipulation of the shoulder. Yes, you can find a little bit, but the rationale doesn't quite make sense. Meaning taking your shoulder and bringing it back and jamming it posterior, I don't think makes sense. It may for some patients, and we need to be able to use the evidence, use our experience to make a judgment call on what we think is going to be beneficial. But what we know about impingement syndrome is that most often they need inferior glide and internal rotation. So consider those things if you are considering manipulation. Now, when it comes to manipulation, though, we still absolutely 100% need to put our chiropractor hat on as far as manipulation and attack the neck. I'm not saying manipulate the neck for every single patient, but with motion palpation, with your findings, address the neck, because a lot of impingement syndrome patients have some cervical nerve root compression. Is one causing the other one? I don't know. I don't think anybody will know. But if you do have a little bit of compression of a nerve, will you have hypersensitivity of the nerve? Absolutely. So we need to make sure we're addressing all the components up and down that chain. And a lot of times we're not going to find an isolated one problem. That's what we'd call a trauma. A lot of these long-standing repetitive stress type issues, postural stresses, have multiple things going on up and down the chain. So it would be foolish not to attack those things. One test that I particularly like is the arm squeeze test to make that differentiation of a cervical problem versus a shoulder problem. What you can see with me pushing down on this model right here is that as I'm squeezing her arm, and I'm just using a little bit of pressure, if I create a lot of compression to a nerve root, which is all of our upper extremity nerve roots are going through that area, I would make her symptoms worse, just like anything else we do. Add a little bit of compression, a little bit of stretch into a nerve. If there's a radiculopathy, you're going to make symptoms worse. Now, what you probably also recognize, I'm below all the rotator cuff muscles. So if she's having pain right here, when I'm pushing here, chances are it's not a rotator cuff issue. If I push here and it makes her symptoms worse, I probably have a neck issue. If I push here and symptoms don't change at all, then it's probably a shoulder issue. So I can't say the arm squeeze test tells me exactly what's going on with the shoulder. However, if I squeeze her arm and it does not change her symptoms at all, I can be sure with a 97% sensitivity, 91% specificity, this is probably not a cervical radiculopathy, it's a shoulder problem. Then I would go through my orthopedic exam to say, okay, not that I can forget about the neck, but I have a primary issue in the shoulder, and that's what I'm going to be attacking with my orthopedic exam. And like I said, this is a McKenzie study. However, it's always a good idea to address everything else. And that even though somebody's not having pain at their spine, it doesn't mean the spine's not associated with that pain or causing the problem. So please make sure you go through and address every single thing. And like we do better than I think most professionals in the healthcare arena, is looking at the most obvious stuff. Is it not being afraid to address the elephant in the room? Is that there's a lot of people who have this posture nowadays. That posture is not a great way to operate. Whether it's talking about the neck, the hand, the shoulder, the low back, anything, it puts us at a huge disadvantage. And our bodies will begin to adapt to that changing posture. So we really want to make sure that when we're attacking the shoulder, and you can all probably do this at home, is that if you have somebody with that rolled shoulder posture, now try to pick up your arm as high as you can. Well, you can't go very far. You're creating a block there. Your shoulder blade can't move because it's already upwardly rotated and abducted from your thorax, and now you're trying to move it and it really doesn't want to move, and you can really force impingement there. If a patient came in and they had this posture and they were trying to get the cup of coffee out of the cupboard, one thing you can do is just work on retractions, forcing some thoracic spine extension and allowing those joints to do what they're supposed to be doing. We often have a difficulty with this because postural things are a habit. Breaking habits are very difficult to break or to form in that respect. So one, telling the patient how important that is will help guide them along their own treatment, but also we can perform spinal manipulation to help get that range of motion. Things like a roll, a McKenzie roll in the back will help. Things like a foam roller will help. Patient education will help. Taking your computer screen and moving it closer to you and up will help. So finding strategies that person can utilize to help fix their own problem. And what we know with manipulation is that if we can perform manipulation, we can start to see positive things happen. We can see an increase in the subacromial space and also improve range of motion in the shoulder. This is one of the things that I think is so important with manipulation, is that we can have a dramatic impact, not only to diagnose someone, but we also have the ability to look at the specific problems through an evaluation and then treat them and then see what happens. And I think that's one of the benefits of the shoulder being a widely mobile structure, is that we can see drastic changes even within a treatment visit. Now, when it comes to the evaluation should be simple. As should most things that we do. My evaluations with every single orthopedic diagnosis are usually done within a minute, 2 minutes, maybe 3. It should be very, very short. And the reason it's going to be short is not based on my skill and ability. It's just selecting the right test to do, to avoid doing too many tests and only do the necessary ones to confirm what we're already thinking when we enter the room. Now, there are certain times that we're tricked, that we're fooled. We think we have a hip problem and it's a back problem. I get that. However, we should really take an advantage of using clinical prediction rules and differentiating tests to figure out, is this a shoulder problem or is it a neck problem first? Something like the arm squeeze test would say, okay, if that's positive when I squeeze that arm and it reproduces shoulder pain and numbness and tingling down their arm, shoulder exam may not be the most pertinent one. Could they still have a shoulder problem? Yes. However, they're probably having more of a cervical root compression type issue. I'm going to go into my arm abduction side, maximal foraminal compression, those kind of tests, my ulnar and radial and median nerve tension test. Whereas if somebody I squeeze there and it doesn't reproduce any pain and instead reproduces shoulder pain, that's when I'm going to start to think, well, this is probably more of a shoulder issue. What's the most common shoulder issue for this painter that's coming into my office? Well, these are the ones that are positive. So it's always good to go into the most likely culprit first, and then if we're not getting those tests positive, then take a deeper dive. So as far as the evaluation, we're going to look at their range of motion. We're going to look at what they can do and can't do. One of the most pathognomonic tests with an impingement is a painful arc. Now, that's something that you can do with the patient, and I'm not saying you don't have to, but mostly they're going to tell you this. So in your history taking, it's, yeah, I can move my arm down here and I can do everything just fine, but it's as soon as I pick my arm up to here, that's when it really starts to hurt. But oddly enough, when I pick my arm all the way up, then it kind of goes away, and that's when the shoulder shoulder blade clears, and now you're able to get that full range of motion. We can also exploit our knowledge of what's going on with impingement syndrome with Hawkins-Kennedy test, Neer's test, and empty can test. Now, the number 1 and 2 tests are these two tests that we're going to see most frequently. I am going to put a little bit of a variation and include my opinion on the empty can test, but really this is a differentiating test. If I have pain with empty can test, then it's confirming more of an impingement syndrome of reproducing the chief complaint. If I have reproduction of numbness, pain, and tingling going down the arm, I still have an empty can test that's positive, but not for impingement syndrome, more of a radicular symptom. If I have weakness upon empty can test, now I'm thinking more of a rotator cuff tendinosis. So this is one of those tests that I use just to make sure that I'm on the right track. But really with 3 tests, we can really make a dramatic and precise diagnosis with impingement syndrome. I'm also big into functional tests. I don't need to do a bunch of them. I don't have 10, 15, 30 minutes to spend with the patient. We do have a pretty fast-paced office, and it's not based on how fast I want to work. It's that my patients don't want to be in my office for hours at a time. So I really try to keep 1 or 2 functional tests under my belt, and it's not based off of a certain system, which is based off what I think the patient may do well with as far as rehab. So can I do things to their scapula? In this case, we're going to cover the scapular assistance. We'll also go through the retraction and repositioning test, and that educates me on what I think I can do for the patient, but also, I think more importantly, educates the patient on what they can do to help their symptoms. So let's dive a little bit deeper into those things. What you're going to see here, if you've seen any of our webinars, is that we have this box here. In this box are all the pertinent evaluations, the pertinent management tools, and also beginning exercises and some more phase 2 exercise and strengthening exercises that we can do for every single condition. We do have a big network of providers that gives us information. We also get all of our information from peer-reviewed literature that is profession independent, meaning we don't look at chiropractic journals or medical journals or PT journals. We look at everything to say, what should we be doing for these conditions? If you had to remove the treatment side of it and you just really had to look at what's proven to work with these diagnoses, how to diagnose it, how to treat it, how to rehab it, how to give ADL modification, what does all the literature say we should be doing? And then we try to synthesize that down into something that we could perform in a chiropractic office to give our patients the most benefit. This section is really the Cliff Notes part of that. So we have that all written out and it's updated on a regular basis as far as a condition reference that when new information comes out, new evaluations, new management tools, new exercises, we videotape it, we put it in there. So it stays live. It stays a constant evolution of a literature review that we can hopefully dig into once a month, make the appropriate changes so we can all practice a little more clinical effectiveness, be a little bit more efficient, and hopefully on the back end of that is better patient compliance and better patient satisfaction. So let's go into the evaluation, and really what I want to cover here are the first 3. The first 3 are the most important because these are the ones that are going to say, okay, this is impingement syndrome. These 3 tests, when done together, should take you around 20 seconds. So it's very, very fast, and it's very, very sensitive to make sure that we have the right tissue that's been injured. Once we know that, we know it's a shoulder problem, we need to make sure it's nothing else. We don't have any weakness in the rotator cuff, and then also we can look at the scapular assistance, retraction, and repositioning test to see is the scapula associated with it. And I do want to make sure that everybody does cover or has gone through that with the scapular dyskinesis webinar, so make sure you check that out if you haven't already. As far as the test, like I said, I don't include this one as far as a video demonstration because often the patient's going to tell you this. It hurts when I do this. It hurts when I'm right between that 60 and 120 degrees. And that's when we really need that shoulder blade to move. And a lot of times it's 1, not moving, or 2, moving too much and creating these issues. So what we will have though is a positive Hawkins-Kennedy test. And this is the most common one that we're going to see associated with an impingement syndrome. What you'll see here is I'm normally right in front of her, but just for video's sake, I'll be a little bit to the side. I'm going to bring her a little bit of shoulder flexion at 90 degrees, 10 degrees of adduction, and I'm just going to force a tad of internal rotation. Now, she's not pushing up. She's completely passive in this process. I force internal rotation. I'm squeezing that supraspinatus between the humerus and the acromion, and I'm looking for reproduction of chief complaint. If this is positive, it can really lead me on the train to impingement syndrome. NIRS test is the second test. That if we have both of these tests, the chance of having impingement syndrome are in that 98% range. She's full internal rotation of the arm, and I'm holding down her shoulder. I'm actually forcing impingement here. So I force impingement on every single person here. I'm taking her as high as she can. She even winced a little bit there. She's got a little bit of impingement, probably from lugging around our children. And so this is one of those diagnoses that when those two are positive, I can be sure that impingement syndrome is my diagnosis. She is passive in that entire range of motion. She's doing nothing. Her arm is dead weight. And what you can see from that, if we just start that video over again, whoops, let's go back one. Is that what you're going to see is that with my left arm there is I'm rolling her into full internal rotation. So I'm really going to force impingement there. I'm holding acromion down. I'm not letting her cheat as some people may, so I kind of hike their shoulder, and we're going to force impingement. And like I said, we impinge everybody. The question becomes, is that reproducing her chief complaint? If she had numbness or tingling going down her arm, if she had a pain somewhere else, while NIR would still be positive, it would not be positive for impingement syndrome. The next is empty can test. And what I talked about before is this is a test looking for injury, inflammation, or weakness within the supraspinatus. So what we're going to have the patient do is in the scapular plane, you're going to have them 90 degrees flexion and picking the arm up for them. I try to do all the work for them so they don't have to create any pain to get into that position. I'm going to stabilize your shoulder, and now I'm going to be pushing a little bit downward as she pushes upward. She's going to be preventing that pushing downward, and we're looking for reproduction of symptoms. Now, one thing to keep in mind, and this will be my opinion, is that I think that this test is a great test. However, I also think it'd be even a better test if it was tested in different ranges of motion. Meaning, what we said from the very beginning is that supraspinatus becomes active, and we start to see any kind of translation upward of the humerus even as early as 20 degrees of shoulder abduction. So I test this at 20, 45, maybe 60, 90, different ranges of motion. And the reason I do this when we get into the rotator cuff lecture is that the amount of tension you're putting across that supraspinatus changes based on the degree of motion, meaning you're going to put different amounts of tension on different parts of the muscle throughout a normal range of motion, and that's okay. But now if you're able to shield that pain at maybe 90 degrees and you're fine, you could still have a positive empty can test if you're in a different range of motion, and that's something that we need to take into consideration. And definitely when we get into a rehab, that's where that range of motion is where you want to perform any kind of an isometric exercise. So that goes through the orthopedic test associated with impingement syndrome. Now, I do think, as far as my practice and as far as the literature, that there are some functional maneuvers that may assist you in one, your treatment, and two, possibly more importantly, patient education, because the patient's going to truly understand how important the shoulder blade is. I have, and I'm sure you have patients that have pain, numbness, and tingling down in their foot or leg. And what do you treat? Usually not that area. Normally it's coming from, numbness and tingling and neuropathy or radiculopathy is coming from the back. And we start treating the back. Well, we need to educate them on why we're treating a different area than where they're having their pain. A lot of times in the shoulder, we're going to have issues with scapular stability, and we need to address that with the patient. So I don't get too heavy as far as patient education at all scapular mechanics, but I need to at least explain to them show them how their shoulder blade is important, so hopefully we can have an impact on their pain presentation. So the first one to cover is scapular assistance test, and this is one I find just most often with my patients that older individuals will have a problem with scapular mobility. As people get a little bit older, they just don't move quite as well. They don't go through a full range of motion. Often what I'll tell my patients is, Bob says he comes in and, I blew up my back and I need to, picking up the rake off the ground. And that shouldn't have caused pain. It's never caused pain before. Or I'll take Sally, who, is getting a little bit older and wants to start running again. And she starts running and now it hurts. So I used to run, but I just haven't done it in 20 years. And I usually ask my patients, listen, Sally, when was the last time you jumped? When was the last time you sprinted, just ran as fast as possible? And often like, well, no, I really haven't done those things in a while. And that's just to show that we're not as active as we once were. And a lot of times these structures just won't move as well or have the same range of motion as it did when you were 20 or 40. Things start to stiffen up. And the same thing happens with the shoulder blade. So the scapular assistance test is going to show myself and show the patient what would happen if the shoulder blade was helped. It was moved appropriately for their range of motion. So we'll take a look at it here. And what you're going to see is the patient's going to pick her arm up and she's going to note when she has pain. Let's say it hurts right there at 60 or 90, 100 degrees, whatever that was. I can actually help move her shoulder blade and she's going to pick her arm up and let me know when it hurts. Now, if I try to do that and she picks up to 60 degrees again and it hurts again, I pretty much know that it's not the scapular motion that's causing her pain. But in this case, she goes to 60 degrees and it hurts. And then I go through her, I stabilize her scapula, and I go through some upward rotation with her, and I abduct the spine and roll her across the thorax. And now her pain goes away. That tells me, and it also tells the patient, that the scapula is involved, that there's a problem when she moves her scapula that is resolved when I move her scapula. So in that situation, I'm essentially being her serratus anterior, which we know is weak with our patients with our upper cross syndrome, our scapular dyskinesis, and now resultant impingement syndrome. And now what would I do as far as treatment? I would need to get her to move her scapula better, and we'll get into that in the management section and how I would do that with my patients as far as in office, and also what I would do with my patients out of office. The next one, which is much more common, would be the scapular retraction test, meaning my older patients will often have an issue with scapular mobility. The vast majority of my patients, and I do have a little bit of a younger population that I do see from my own practice, maybe under 45, they have an issue with scapular retraction, meaning their scapula has too much motion. My baseball players, my overhead athletes use their shoulders so much that it's become such a wet noodle that it has too much range of motion, and they need a little bit of help with stabilizing their scapula. So once again, I would have them move their arm and see how high they can go, and I would note exactly where that pain is and when they're moving their arm. And let's say she picks her arm up and it hurts right there, maybe 150 degrees. What I'm going to do is I'm going to stabilize her scapula, and I'm going to actually push down, become her lower middle trap. I'm still going to allow the shoulder blade to move though. I'm not pinning it there. I'm actually creating some downward and medial force, but still allowing the scapula to move upward. So what I would call that is posterior tilt. I'm not pinning the shoulder blade back. I'm not setting the scapula. I'm still letting it move, but I'm creating a little bit of compression there in posterior tilt. And one thing that you can do for yourself is if you put your hand right here on your acromion and you take the inferior polar of your scapula and just tilt it backward, just contract that lower trap, that serratus anterior, you can feel how that acromion moves backward. It's changing the position, the orientation at the glenohumeral joint. And then I'm allowing them to move their range of motion. So by doing posterior tilt, by essentially me forcing that, I can increase the subacromial space and get her to go through that range of motion without having pain. That's powerful. It's powerful for me as a practitioner because now I know what I need to do. That not only can I do my management tools to help get her out of pain, but I also need to consider some rehab exercises to help keep her out of pain, which would involve strengthening of the scapular stabilizers and teaching her how to posterior tilt her scapula during those strengthening exercises to help promote that stability. And that's what the next test is that most of our tests we would consider something that we're doing to a patient. And the repositioning test begins with that, but really this is a patient educational tool. So what I need to do is to convince the patient here, if we call this the inferior part of our scapula, I need to convince the patient that you have a muscle that goes from here and attaches to your spine. Technically, there's not really a muscle that does that one thing. I understand that. However, most of our patients understand things at a 6th or 7th grade level. She doesn't need to know all the muscles in her shoulder blade. She needs to know that she needs to contract the muscle that attaches here to here. So what you'll see with my hands is I put my hand there and I just pinch that area together and let her understand what I'm trying to accomplish. Now, what we know is that that takes a lot of compression and activation of the serratus anterior and of the middle trap to perform that maneuver, but she doesn't know that. So what we're going to do is we're going to have her perform a posterior tilt exercise of the scapula. So I'll put my my left thumb right there on the scapula and I'm just going to pinch backward, teaching her how to do that. You need to pull that down, and now I want you to hold that with 10-15% of your force and pick your arm up. Now my hand is there, I'm teaching her how to do that. However, I'm not actually doing anything while she's performing that movement. Often what you're going to find is similar to the scapular retraction test, is she's going to be able to go up a little bit higher. Now when you perform the scapular retraction test, she'll normally go to full range of motion, if that was her condition. Once she does the repositioning test, just because she's used to using that scapula in a different way, she may not go quite as high, which is okay. That's affirming that she needs us to help her with that process. We need to do some things as far as rehab and as manual therapy to get her shoulder blade to move better, and also teach her how to activate those muscles with our rehabilitation. So a very simple way of educating our patients on that. So the evaluation, just to recap, is that we're going to do these 3 tests. If they reproduce her chief complaint, this should take about 30 seconds. As far as anterior lateral shoulder pain, we have a diagnosis of impingement syndrome. We're going to just check to see these different scapular assistance, retraction, and repositioning tests. We also keep the isolated strength test in here, which we're going to go over in the next section. So we're going to go over if there is weakness upon the empty can test, then I'm going to dive into all the rotator cuff muscles and to see, is there a weakness? Is there a possibility of a tear, a rupture, or severe tendinosis that's limiting the strength of that tissue? So we'll cover that in the rotator cuff section of this continuing education. The next piece is the management. The management of impingement syndrome should be quick, simple, and only include the things the patient needs, meaning I have a recipe behind 98% of the things that I do in my practice. That recipe does change based on the diagnosis, obviously. However, it allows me time to focus on the 2% of things that really matter to a patient. Maybe some of these impingement patients, it's sleeping. Maybe it's workstation ergonomics. It's the patient education piece that I can focus on. But as far as the treatment, the literature is fairly clear on this, is that we can do things to help alleviate the pain as far as this diagnosis, and we can also do things to help that specific patient get better faster. So what we'll talk about a little bit is mobilization of the shoulder, depending on which ranges of motions are lost, and also go through some scapular mobility to help improve that motion. And then we can also go through the exercises at the very end. So here are the things that we're going to do for the patient as far as the management tools. All of our videos, please don't take offense to this, have the muscles drawn in. I understand that you know where the muscles are. However, use this for a lot of schools and as far as student education. Where you see X's are going to be where the common trigger points are located as far as Travell and Simmons. And as far as the videos will have sound associated with that when you access them via our platform. However, for right now, I'll just narrate through it. What you're going to notice is that a lot of these tissues are going to be painful, and they have trigger points, if some of you may call it that. They have tight spots in that, but really what you have are muscles that are working too hard. And it's often not one muscle, it's often all the muscles. What we know from the shoulder is that a lot of times the muscle going across here, being the supraspinatus, is a little bit weaker due to constant insult from the impingement syndrome. Well, you only have 4 muscles, and those 4 rotator cuff muscles, which we'll dive in deeper in the rotator cuff section, form a sheath over this humerus, and they try to pull the humerus down as the top muscles, the deltoids, pull it upward. Well, if one of the muscles that's involved in pulling it down and compressing that isn't working quite as well, the other muscles have to work a little bit harder. So a lot of times you'll have tenderness in here, you'll have knots in here right along that shoulder blade, and the person doesn't even know they're there. So things like ischemic compression, pin and stretch, soft tissue are very important to help alleviate symptoms, but are more so of a sign of dysfunction as compared to a solution to the dysfunction. One commonly missed, possibly because we don't like getting in there, possibly because it's just in an awkward position, is the subscapularis. And I want to bring this to our attention though, and I'm going to pause it really fast because this is a muscle that unfortunately does not get a lot of press, however has one of the best mechanical advantages to pull the humerus downward as you're going through shoulder range of motion. And this muscle, it just takes the brunt end of any kind of impingement or rotator cuff problem. So I really want to make sure that everybody at least addresses this. One thing to keep in consideration is you have some important stuff going through here, this being the neurovascular bundle. If you start to do soft tissue, myofascial release, manipulation, what have you, in any part of the body, and you start to have the patient experience numbness, pain, tingling, sharp pain, radicular symptoms, peripheralization of symptoms, it's time to stop. And this would be one of those areas that I will bring that to your attention because you are flirting with some blood vessels and arteries that have some impact on the upper extremity. So when I do this though, and we can't obviously impact the entire subscapularis, which is notably for stabilizing shoulder blade and for as an internal rotator, that I want to make sure we stay in a safe spot. We can't contact the entire subscapularis as it dies underneath the the ribs and on the front side of the shoulder blade, but what we can do is we can attack where it does insert into the humerus and we can stretch it out. I'm going to bring her up into full extension and external rotation when I get this range of motion. And I'm really going to dig in there and try to do some movement stripping, some pin and stretch, or whatever soft tissue technique that you do. I'm not a technique guru. I've taken my fair share of seminars. I think they all have validity. I think that the one thing that you need to do is just own whichever ones that you do, whichever seminar or technique that you're great at. As far as the supraspinatus, this is one that's often the culprit behind impingement syndrome. However, very rarely will I be too aggressive in treating it at the very beginning, and just because it's already irritated. So doing some simple pin and stretch, some movement stripping, whatever it is that you do as far as instrument assisted manipulation, just be careful when you already have an irritated tissue. We don't really want to make it a whole lot worse. So be very careful at the very beginning. And you don't want to cause excess compression and excess irritation of a tissue that's already irritated. So being very clear on what you're doing and why you're doing it. And once you're on the downside of treatment, it's always a good idea to treat those areas. And if there's areas of tendinosis in there, it's good to go through a full range of motion. As far as the teres minor, this is going to look very similar to the infraspinatus, but the teres minor has a little bit better of an orientation on the humerus to pull downward. And like I said from the infraspinatus talk, is you'll find a lot of trigger points right along that outside part, lateral border of the scapula, that a patient often didn't even know they had. So that'd be one thing to consider, along with palpating that area during your orthopedic exam. When you do the movement stripping or soft tissue, it's going to look very similar to the infraspinatus. But one thing you can do is you kind of pick the arm up at the very end and go a little bit higher there, and to get a little more range of motion out of that muscle. Normally for these stretches, I would actually be behind the patient, but just showing for this class, it's a little bit easier if I stand to the side. Mobilization of the glenohumeral joint. This is one of those things that some people get bent out of shape about, and I have to be honest with you. This is a huge waste of time if you stretch someone out in all ranges. What you really want to do is, like everything else, testing side to side. Look at flexion, look at extension, internal rotation, external rotation, and look at the range of motion that is limited on the painful side. So is it flexion? And if it is flexion, then you can take them into a range of motion and work them into flexion. I can do this. I like to do it from the elbow, just one less joint to worry about, like this. I can also do this in extension and internal rotation. I don't do every single range of motion on every single patient, only ones that are positive from my initial evaluation. A lot of times the shoulder, it's going to be extension and internal rotation being the most common. You can go through a gentle mobilization at end range, like you see me doing here, or you can do a contract relax stretch. It's whatever you're accustomed to, whatever works best for you. Remember that when you're doing these kind of mobilizations, that sometimes that person is going to have a little pain or apprehension, so you want to make sure you're nice and comfortable. I like to lay the person down when I'm doing this because it can remove all those postural muscles. So once again, doing some simple mobilizations, or you can actually take them up in different ranges of motion and do contract relax stretches. You can even go into, which is I think is the most common range of motionless loss, is internal rotation. And if there's an internal rotation deficit that's 20 degrees or more on that painful side, it's something to attack. One thing I'm doing here is a little bit of a contract relax cycle, so she's pushing up. Mobilization extension. And then she can also do a contract relax where she's pushing her hand up into my hand and I'm pushing down, which is on a different video. So whichever ones you're comfortable with as far as treating each individual patient. Exercises. So the exercises for impingement syndrome are going to look very similar to scapular dyskinesis. And the reason that's the case is because what we know is that 100% of people with impingement syndrome have signs and symptoms associated with scapular dyskinesis. So you're going to see some overlap as far as the exercises, along with some new ones. So the first one, possibly my favorite one, is the YTWL. When you have a patient do this, you really are focusing on all the muscles associated with scapular stability. And I'm just going to back up a little bit because what I think that from this view you don't see quite as well or appreciate quite as well is her arm movement. So when you do this, you want arms up, but you also want the arms all the way back as far as possible when you're in that Y position. When you drop to the T position, bring your arms even further behind your body. When you drop to the W, you're gonna have your elbows down and bring your elbows behind your body. And then L, your hands are gonna be at 90 degrees, or elbows at 90 degrees, and bring your hands back behind your body. And when you can do all those, the Y, T, W, and L, you can activate all the muscles associated with scapular stability. And it really helps open up the front of the chest, but the corner pec stretch does this, and I'm going to slow this down just 1 second right here. The corner pec stretch, which is probably my favorite stretch for the anterior shoulder. We'll see it in scapular dyskinesis. You're going to see it in impingement syndrome, and also thoracic outlet syndrome, with one little caveat. So what you'll see with this one is that the patient's going to have her elbows right here at 90 degrees. Now you can modify this elbow angle. So if somebody does have pain when picking their arm up, you can drop this elbow down to here. But what she's doing is she's just using her elbows and her hands, and she's pushing into the wall. And when she pushes into the wall, she's activating those pec muscles, and then when she relaxes, she's able to drop in a little closer to the wall. After about 5 or 7 seconds of contracting, she's going to relax, and she'll drop her body a little bit closer to the wall and do a little extra stretch, which you saw there. Then she'll contract again, lock in a new range of motion, and then sink into the wall again. So this is a great way to mobilize the front part of the chest and the pec major and minor. Glenohumeral internal rotation. This is one where there's a little bit of debate on this before I play this one. Is it the sleeper stretch, a side-lying posterior capsule stretch for the shoulder that was a little more common many years ago? This is still a great stretch. However, the one problem that I have with that stretch, and this is my opinion, is that you're laying on your shoulder. So you're laying on your shoulder and you're pushing downward. And what we know with impingement syndrome is that kind of compression isn't conducive to healing. So I do favor this stretch for glenohumeral internal rotation a little bit more than that traditional stretch. And this is bringing the arm behind them. And remember, a lot of these patients have difficulty with putting their bra strap on, tucking in their shirt. So you want to do this in a range of motion that's not causing pain. And she's going to use her left arm there, and her right arm is just dead weight there. And she's going to take it into an end range of motion and pull a little bit further. And she's just doing a gentle mobilization into internal rotation. I often have my patients do this hourly. It's not so much a 1 time a day, 3 times a day, but it's every hour. I want you to just go a little bit further. there are some patients who are unable to do that, meaning they can't get their arms together, and that's okay. With those patients, you want to have a broomstick or a towel, and they can grab the towel or the broomstick with one hand and use the other hand to pull it behind their back. And eventually that range of motion will get better and better. In fact, what you'll see most often is that range of motion will get better throughout the day. When they first wake up in the morning, they won't get as much range of motion. Towards the end of the day, it'll get better and better, and hopefully that range of motion will come back. Codman pendulum is a popular exercise. In fact, we'll see it with many different diagnoses. However, with the impingement syndrome, I normally had them start off without a weight and just having the arm be dead weight and just kind of let it dangle there. And we can also add in a weight if we really want to. So have a weight being used to distract the arm and pull it downward. You really want to just use the arm to get some more range of motion and let it be kind of loose there. And then as they can do that range of motion without pain, add in some weight. A lot of times people will have the arm be dead weight when they're using a weight, and I don't have any issue with that. I think that using your arm in a range of motion that's different, meaning you're not gravity bound, you're not posturally driven, will help get that range of motion up there. And if you think about it, when you're down and your arm's here, it's actually way up here. So she's getting a range of motion, if you look right there, that's technically, maybe 145, 150 degrees of shoulder flexion. So we're just using different muscles to achieve that joint range of motion. Here is one exercise that I don't agree with. This is my opinion and not based on evidence. The evidence says that a cross-body stretch is very good for impingement syndrome. So here it is. What you're going to do is you're going to bring your arm across your body, take your opposite elbow and hold your elbow like you're going to see here. And what she's going to do is she's going to take her right elbow, in this case, she's going to push back across her left elbow. So she's going to do a contract, relax cycle where she pushes, then relaxes and goes. She's pushing right now, and then she'll relax and go a little bit further. While that will stretch out the posterior capsule, will stretch out the infraspinatus and teres minor, that also looks a lot like what? The Hawkins-Kennedy test. So I'm not a huge fan of this test because it does force some impingement. Now, one thing to consider is that she is up like this, and that's what you see most common in the literature. If you bring your arm down, if you bring it down closer to your belly button and do the same thing, you can get a similar stretch. So bring it across, take your elbow, push into your hand, hold for 7 seconds, relax, and go a little bit further. I'm still not a big fan. Like I said, just my opinion. I'd much rather someone be successful with the other exercises than the possibility of hurting themselves with an exercise with a little less value. And then I like to load people up. I'm a big person on exercise. I like to give them to start to do some strengthening exercises. The low row is a safe exercise, meaning they're not picking their arm up into those impingement ranges of motion. It's just able to activate some of the shoulder blade muscles. With that being said, just bringing your arm back really does right about nothing. So you really want to bring it down and use your scapula, do a little bit of posterior tilt, and let your scapula squeeze together and down when you're doing that range of motion. You want the scapula to move. You do not want to, what I've heard is set the scapula in the back pocket, scapular setting exercises. While I like the motion that those exercises do, we want the shoulder blade to move as your arms move, like they're designed to move. So low row is a great exercise. Personally, as far as my exercises, and I only like to prescribe 3, maybe 4 exercises for a specific patient. So I would actually favor this exercise. This is what I use for my protocol when I prescribe my condition report for impingement syndrome, is a Brugger. And the reason is because her arms are supinated, which is going to force her to have less impingement. And also when she brings her arms back into extension, she's not going to get impingement. And what she is going to get is activation of the serratus anterior. So this is a great way to help force a little bit of range of motion, keeping her chin retracted. She's standing up tall, and she's forcing some scapular stabilization. So I think this is a little bit easier to do. Sometimes patients have a little bit of difficulty with wrapping this around their hand. For what reason, I don't know. However, a simple band is a great way to accomplish this. I don't like a lot of tools and a lot of things that my patients have to buy, and not that I don't think that they're beneficial. It's just that whenever I prescribe something that requires a weight, a band, a foam roller, a specialized device, a lot of times that exercise won't get done, or they forget it at work, or they don't bring it to work. So finding ways and tools and exercises that someone can do that don't require a lot of space, that they can do at home or they can do at work, really go a long way as far as compliance, because you have to make sure it's realistic for that patient to do. And like we said before, an educated patient is a compliant patient. If they understand what you're working to accomplish, a lot of times they're going to work just as hard to help with their symptoms as you're working to get them out of pain. So this is going to conclude the impingement syndrome lecture. Like I said, it would be beneficial to also, if you haven't already, looked at upper cross syndrome and scapular dyskinesis. What we're going to do moving forward after this lecture is now we're ready to really get into the fine-tuned parts of the shoulder. And the reason I say fine-tuned is because impingement syndrome is, like we said, a syndrome. It's showing some dysfunction. We have some irritation in the subacromial space, but it really doesn't say this is a bursitis, this is a slap lesion, this is a rotator cuff problem, this is a biceps tendinopathy. There's a lot of different things that can cause pain in this area. So the next set of lectures, one being rotator cuff syndrome, but really getting into even things like TOS, even things like your biceps and your slap lesions, will have this as a precursor, impingement syndrome. So we'll see a certain diagnosis, but there's layers to an onion. There's layers that as you start to treat one thing, they start to show the predisposing factors. And what I find most often is that this is one of those precursors, the impingement syndrome, and that someone comes in with a specific isolated lesion, like a rotator cuff problem, like a labral lesion. And those are the things that once those pains and problems go away, then you're left with impingement. Once the impingement syndrome goes away, then you're left with a scapular dyskinesis. And then, of course, they're hopefully out of pain then and also in the future. So thanks for listening to this lecture on impingement syndrome, and I look forward to seeing you again with the rotator cuff syndrome.